Okay, today we're going to do a neurologic exam. And although part of the checklist can be verbalized instead of demonstrated, I'm going to go ahead and demonstrate it today just so you can see it put together. But when you do the checklist, you can verbalize the parts that say verbalization. For your neurologic exam, it is an option to put out all your equipment in advance, and that will also help clue you if you forget to do an item. Charmaine, so glad to see you today. So first, we're going to do a neurologic exam, and we're going to start with your sense of smell. So could you just close off one nostril and sniff? And then the other side and sniff, okay? And then I need you to close your eyes and close one nostril again, and then tell me, sniff and tell me what you smell.
Soap.
Okay. And then we're gonna do that again with the other side. And then tell me what you smell.
Coffee.
Perfect. Okay. Now you can open your eyes, and I'm gonna have you check your visual acuity. So if you could hold this about here, about 14 inches. Now we're going to check your visual fields, which is sort of your peripheral vision. So I want you to, for this I need you to look off into the distance, and I'm going to look in the back of your eye, so I'm going to get really close to you, okay? That completes cranial nerve 1 and 2, and then for 3, 4, and 6, we're gonna take a look at her eyes and notice that there's no ptosis. The pupils appear symmetric and round, and then we're gonna check her pupillary light reaction by shining the light. Then for accommodation, I'd like you to look off into the distance, and then I'd like you to look at my finger. We're going to check your extraocular movements. So I want you to look at my fingers and keep your head still and just follow my fingers. Okay, with your eyes only. Don't see the whites of her eyes on the outside, but that she's fully, and then check for convergence with the movement of the eyes inward. Okay, so that completes 3, 4, and 6. For cranial nerve 5, we're going to test pain sensation on the face. And we're going to use a Q-tip. You want to break it away from the patient and then check to see if you have a sharp end, and then you can use the Q-tip for the dull end. Okay. Then you want to demonstrate on your patient's hand to see if they can tell the difference. Can you tell that's dull? And does that feel sharp?
Yes.
Okay. So I'm going to touch you on your face in different places, and you tell me whether it's sharp or it's dull.
Okay.
So I need you to close your eyes. Okay? So the test is really the sharp, and then the dull is used as a control. So is this sharp or dull? Whoa!
Sharp. I'm good.
I could tell by your reaction. And now?
Sharp.
Okay.
Dull. Sharp. Dull. Sharp. Sharp. Sharp.
Okay. Good.
Yeah, a lot of
It was really
sharps.
sharp. So you have to get sharp in all 6 locations, and then periodic dulls. Okay. All right, and then if that was questionable, which it was not, it was clear that she could tell the difference, then we could do light touch sensation and temperature sensation, or corneal reflex. For the motor component of cranial nerve 5, then we want to check for movement of the jaw. So could you open your mouth and then close it tight, and you ask the patient to clench, and you can feel the engagement of the masseter muscles and the temporal muscles. She does it. For cranial nerve 7 facial, we want to look at the symmetry of the face, and she has symmetric creases and no evidence of any kind of palsy, no tics. I need you to raise your eyebrows, and then I need you to frown. Show me your upper and lower teeth. Good. And then I want you to close your eyes real tight and keep me from opening them. Okay, perfect. And then if you want, it's an option to have the patient kind of puff out your cheeks. And then I'm just going to push a little bit, and she's got good strength there. Okay. Cranial nerve 8, we're going to test for hearing. So could you close your eyes? Okay. And then if there was any question with that, then we would do the Weber and the Renee testing. During the course of the examination, she's verbalized, and I haven't noticed any issues with her voice, but you can clarify asking, have you noticed any problems or any changes with your voice? Any hoarseness?
No.
No, nothing different?
No.
Okay. All right. And have you had any difficulty swallowing?
Oh, no.
Okay. So could you open up real big and then say, ah, ah. Okay. Perfect. Now, if I was questioning cranial nerve 9 and 10, then I could stimulate the posterior pharynx on one side, see if she gags, stimulate it on the other side, and see if she gags. But for 11, for spinal accessory, I want you to shrug your shoulders up against my hands. Perfect. And then over here, I want you to push against the heel. Okay. And then push over here. So I'm testing strength, but I'm also looking at the sternocleidomastoid to see that she has the engagement of that muscle, and I don't see any twitching or fasciculations. All right, and last for cranial nerve 12, I need you to just open your mouth. And I'm looking at her tongue, and I don't see any abnormalities. And then just stick it out, stick your tongue out, and move it back and forth. Okay? If there was any question about movement or strength, you can ask the patient to push their tongue against the side of their cheek, and then you can feel there, and then do it on the other side. That concludes the cranial nerves. So for sensory testing, it can be done in a sitting position or partially sitting and partially lying, but I'm going to do the whole thing in the lying position and show you how that works. So when you're doing pain testing, it is also an option to hold out the sensation on the face with cranial nerve 5 and incorporate that into the overall testing, or you can do it separately as I've done so far. So just to make sure, you can tell that that's sharp, obviously. Yes. And that's dull. Okay. And you can do the hands on this side, the hands on that side, and then do each component comparing side to side, but don't do the whole right side of the body and the whole left-hand side of the body. Okay, so with your eyes closed, tell me if this is sharp or dull.
Sharp. Dull. Sharp. Sharp.
Okay, and then we're going to do this hand.
Dull. Dull. Sharp. Sharp. Dull. Dull.
I'm going to check again. If you're not sure about a response, then you can double check it. What was that?
Dull. Sharp.
Okay. Then for T4, you want to go approximately at the nipple line. We're not going to demonstrate that, but you could just pull down and then be approximately on one side. Is it sharp or dull?
Do it again.
Sharp? No.
Dull. Sharp.
Okay. All right, that's T4. For T10, pretty much you're right at the umbilical line. And tell me if this is sharp or dull.
Dull. Dull. Sharp. Dull. Sharp.
Okay. And that's T10. For L4, we're above the knee. And continuing on with our plan, tell me if it's sharp or dull.
Sharp. Dull. Dull. Sharp.
Okay, great. And then you want to do, sometimes there's callus formation on the feet and they won't feel the sensation as well. So if that's the case, underneath the toes or right on the soft spot of the toe is a good place to pick up that sensation. For L5, you can do here, the second toe.
Sharp.
Okay. And then S1.
Dull. Dull. Sharp.
And then compare to the other side.
Do that again.
Hard to tell.
That's dull.
Right. When you get to a certain point, sometimes your stick gets dull. Let's try a new pointy stick. Okay. All right. Now.
Sharp. Dull. Sharp. Sharp. Dull.
Okay. Good. Great. So you want to do the feet last because you really don't want to be poking other parts of the body after the feet. All right. Then we want to move on to vibratory sense. And this time you're going to use the 128 hertz tuning fork. And you want to start by putting it on a distal joint. Vibratory sense is going to be one of the first senses lost, and it's going to be lost most distally first. So we'd like you to test a distal DIP joint in one finger on one hand, same finger in the other hand, and then also on the foot. If the patient wasn't able to feel the vibration on the hand, then you would start moving up, placing this over bony prominence. So I'm going to touch you and tell me what it feels like. So just close your eyes.
Vibrate.
Okay. And then tell me when it stops.
Stop.
Okay. That's one technique for testing it. The other technique is, tell me, is this vibrating or not?
It is.
Okay. And now, vibrating or not?
Yes.
Now?
No.
Okay. So you don't want to just ask your patient if they feel it. You want to know if they feel vibration. Okay? So then we're going to do the same thing on your toe. And tell me what it feels like.
Vibrating.
And then tell me when it stops.
Stopped.
Okay. And then is this vibrating or not?
No. Now it is.
Okay. So I would just stick with one technique or the other, but I was just demonstrating both ways. Either way would be fine. Okay. Now for proprioception, we're going to do this on a finger on each hand and on a toe on each foot. There's a couple technique issues. You want to stabilize the middle joint and just move the distal phalanx. And you want to make sure that your fingers are on the side of the patient's finger or toe, because if it's on the top and the bottom, then they feel pressure clues as opposed to just feeling the positioning of the joint, okay, or the phalanx. So you can demonstrate to your patient by showing them a larger finger. So can you tell that this is up?
Yes.
And that is down?
Yes.
Okay. So then I'm going to test this finger. The other thing you want to be careful about is as you move it, you don't want to be right next to other fingers, because as you slide past them, then they get secondary clues that tell them what's going on. So tell me whether your finger is down or up.
Down. Down. Up.
Okay. And then tell me if your finger is up or down.
Up. Down.
Okay. And then I'm going to go to the toes. So the toes are a little bit trickier because it's harder to get the other toes out of the way, but you just kind
That's
of
down.
move those over. Okay. And then tell me,
Up.
so we're going to stabilize this joint and then tell me if it's up or if it's up or it's down.
Down. And up.
Okay. And then over here.
Up. Down.
So for stereognosis, then you ask your patient. So I'm going to give you something in your hand. I need you to have your eyes closed, and then you tell me what it is. Okay?
Okay. Key.
Okay. And then this hand.
Pen.
Good. Great. All right. Okay. So that's our sensory testing. Now, moving on to motor, one thing you want to assess is whether your patient is right or left-handed. So just asking, are you right or left-handed?
Right.
Okay. And then we want to note the kind of the bulk and contour of muscles. So just comparing right and left arm. And since she is right-handed, I would not be surprised if there'd be a little bit more bulk in the muscles of the right arm. Also with the legs, then taking a look at the muscles, comparing, there doesn't seem to be any atrophy. I don't see any tics or any fasciculations, any unusual movements. All right. And then you want to just get a sense of the flexibility of joints and the reaction of muscles to passive range of motion. So, so there's no limitation here. I can check her elbows, shoulder. Thing is fluid on that side. Fingers, wrist, elbows, shoulder. Okay. For the legs, this is a draping issue, so you want to kind of cover up one leg while you move the other one. You can hold the bottom of the foot and then just bend the knee, stretch it out, move it around. She's got good tone. There's no rigidity or any kind of cogwheeling or any reaction to any of my movements. Now we're going to move on to strength testing. So strength testing is really important to compare right to left. In fact, almost everything on the neurologic exam is important to compare right to left. But we're going to start with hands. I want you to squeeze my fingers real tight. Okay. And then I want you to put your wrists up like that, and I'm going to try and pull it down. You stop me. Okay, so wrist flexion. And then I want you to spread your fingers out like that, and I'm going to try and squeeze them together, and then you try and stop me. Okay. And then I'm going to put my finger under here, and you try and, like, you can make a fist, but try and push my finger down. Okay. And then on this side, I'm going to resist thumb flexion. Okay. For the biceps, I'd like you to pull up against my hand. So try and make it biceps curl, and then you can compare that to this side pull up. Okay. And then with your hand up like that, push against my hand, and then against over here. Okay, good. Lastly, put your arms out like that, and you don't want to be below the elbows because that can put some stress on it, but I'm going to try and push your arms down, and you stop me. Okay. Whoa, they're very strong. Excellent. All right. Then that's upper body. And then for lower, Some of those other ones, it's okay to do both together. You can ask the patient to, like the shoulders and the triceps, you can push against and pull back. But for hip flexors, you definitely only want to do one leg at a time because it's too stressful on the back to do them both at the same time. So you put your hand here, and I want you to lift your knee up against my hand. Good. And then on this side. Okay, good. And then you can kick out against my hand and then pull back. Okay. And then pretend like you're pushing down on a gas pedal. Okay. And then do the opposite, pull up against. Okay, perfect. For coordination, we're going to check rapid alternating movements. And these are okay to do at the same time, but I'm just going to demonstrate them on each hand separately. So I want you to take your hand and flip it over like that. You can do it like I'm doing it. Okay, and then do the other. Perfect. Okay. And then for feet, I want you to tap on like your whole foot. Tap, 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 tap. Okay, and then over here. Okay. They can also do it on the, like on the footrest.
Do it there too?
You can just tap on there. Great. Okay. You can do finger tapping, so you just tap this over and over, and then on this side too. Okay, good. All right. Now, heel to shin and finger to nose can be done sitting or standing. Sitting is probably best for this. So it's important when they're doing finger to nose to make sure that they have to stretch their hand all the way out, their arm all the way out, because that's when you see the tremor, is when it's fully extended. So if they just go to here, you may not see a tremor in a person that has a tremor. So you want to move your hand in different planes, and you want to have it far enough away that they have to reach out for it. So I want you to touch your nose, and then I want you to touch my finger, and then touch your nose, and then touch my finger, touch your nose, touch my finger, touch your nose, touch my finger, and then we're going to trade and do the other hand. Nose, and then finger, nose, finger, nose, finger, nose, finger. Great. For heel to shin, you just demonstrate it. It's easiest for a lot of these neurologic things just to show your patient what to do. So they put their heel up below their knee and then just slide it down to the foot. And then do the same thing on the other side. Great. Okay, perfect. To evaluate her gait, we first want to just watch her normal gait. So do you mind just walking across the room? And then turn. And you want to note how easy it is for her to turn. And then I want you to walk back like you're on a tightrope or, yeah, perfect. Good. All right, and then I want you to walk back toward me on your tippy toes. Okay. Good. And then turn around and walk on your heels. Okay. Then I want you to hop on one foot 2 or 3 times. Okay, and then the other foot 2 or 3 times. Okay, great. And then try and just do a shallow knee bend and up. And then a shallow knee bend and up. Okay. And so that's adequate for most patients, but particularly in elderly patients, it would be difficult to do most of those, but especially the knee bends. And so another test you can do is to have them rise from a chair. So do you mind sitting there? So without using their hands, you just ask them to stand up. Okay. Really easy for Charmaine, but not so easy for somebody who's... So then 2 more tests to evaluate the coordination and sense of balance. So first thing to keep in mind is that you have to protect your patient, so you have to make sure that you're prepared to catch them, and you should not do this test if your patient is unstable and unable to walk or unable to stand. if you could stand here. So if I'm going to time this for 30 seconds. So if I don't have a watch and I'm going to be using the clock, I need to make sure that the patient is between me and the clock and not me turning around away from the patient and not aware if she was falling. So for the Romberg, you want the patient's feet to be right next to each other and their hands right down there. And then you want to just assess if she's able to stand in that position with her eyes open. So I just wait a few seconds. She's very steady. And then now I need to be prepared to catch her. So I need to be here. And then I need to be able to see the clock as well. So now I would like you to close your eyes. And I'm going to have you keep your eyes closed for 30 seconds. Okay. And so a normal test would be that she might sway a little bit, but she's able to stay in that position. But if she has to step out to balance herself, that would be a positive Romberg. Okay, good. And then lastly, we're going to do pronator drift. This can be combined with the Romberg, but I'm going to show you a way to do it separately. You can do it with them standing or you can do it with them sitting. So similarly, you're going to go like this with your hands straight out. And then I'm going to have you close your eyes, and we would do that for 30 seconds. But like I said, you can combine this with the Romberg. Just be prepared to catch. And then the last thing you want to do is just check. If you do that, normal healthy patient kind of responds quickly to the pressure. And pronator drift would be if one hand dropped down and pronated. Okay. Good. Reflex is another component that has to be compared immediately, so you're not going to do all the reflexes on one side. You're going to do biceps, biceps, triceps, triceps. So the biceps tendon is right here. If you're not sure where it is, you can have the patient pull up as in a biceps curl, and then you can feel it engage. And so for this reflex, you want the patient to be relaxed. And then you're going to press down on that biceps tendon, and you're going to actually hit your thumb. And you may see movement, but you definitely feel it. I can feel it engage. I can move over to the other side, but you can also just reach over from here and then do it on this side. And again, I can feel the engagement of the biceps. So triceps can be done in this position, but it's much harder. But if you were to do it this way, then you make sure they're relaxed, and then you're hitting right above the elbow. You want to avoid hitting the actual bone because that can be quite painful, but above it, and you're looking for movement of the triceps. But like I said, that is difficult to get in that position. Easier is to get the patient to relax their arm. Usually if you take the arm, you're more likely to get them to fully relax it. And so then you want to make sure they give you all the weight of their arm. And you can hit it with a flat end, and you're looking for outward movement. And if you don't get it that way, then you can hit it this over here. And there. We got a little bit on that side.
Yeah, what's going on?
And then I'm going to go over here, and when I do it this way, I hold their arm and I kind of brace it against my hip. Whatever works for you, but particularly with the, like a guy that has a really heavy arm, it helps me to give it some support as I'm doing this. So then I'm trying to hit that location. Sometimes I try it with the flat, and sometimes. So 2 or 3 tries, and if you don't get much of a reaction, that's okay. All right. So the brachioradialis, you want their hand relaxed in their lap and slightly pronated, and you're going to hit above the wrist. You can hit directly onto the tendon or onto your thumb, and you're I'm not getting, and it's down. If you lift your thumb up, then you can feel that tendon, and then you're going to go just slightly medial to that. So then just relax again. I'm not getting. Let's try here. So patellar, make sure that they're not having their feet up against the footrest, and then try not to actually hit the patella, but below it, I always feel. And then you do not want to be directly in front of your patient, or if they're hyperreflexic, you're going to get hit in the face. So, and it's easiest if you're right-handed that you're hitting this way as opposed to backhanded. So usually I just stay, I'm right-handed, so I stay to the patient's right. I hit there. If I don't get it well, I can sometimes do the pointy end, and then I compare immediately to the side. Okay. And if you have difficulty with that, then the distraction technique should, I want you to pull when I say 3, okay? 1, 2, 3. Okay? 1, 2, 3. Good.
This side is better.
Yeah. All right. So for Achilles, you have to stretch out the Achilles a little bit, so you actually have to flex the foot up slightly, and then you're looking for the downward flexion of the foot, and so you just hit back here and make sure she's relaxed. A little bit on this one. Okay. Then while I'm down here, I can check for clonus. So basically I want to get her foot nice and relaxed, and then I want to pop it up. And she does not have clonus. If she did, when I did that, then I'd get this. Okay. So you primarily will look for that if you had a patient that was hyperreflexic. All right. Then for the plantar response, we have often used this end of the reflex hammer to do that in the past, but I've come to believe that's a bad idea because we don't clean it. So you can get the same response. It's not as sharp just using a tongue depressor. So what you want to do is just stroke up from the heel on the outside of the foot and around, and you're looking for whether the toes flare out, whether they curl under, or they just remain neutral, which hers are more or less neutral. Let's see how this side. As long as they don't flare out, we're okay. Then during the glabellar, you can just tap your patient right here, and you're just noticing if they have excessive blinking when you do that, and that would be a sign, possible sign of Parkinson's. So lastly, we'll do the mental status. And over the course of the visit with the patient, I've been noticing her response to questions and her affect, and haven't noticed any indication of a depressed affect or inappropriate responses to questions. But then I would want to go ahead and ask her questions. Are you feeling sad, down, depressed today?
Oh, I'm fine. I'm happy today.
Any particular stresses going on in your life?
Not at the moment.
Okay. How's your mood been lately?
Pretty good.
Okay. All right. And then to evaluate her mental status in terms of awareness, do you know what today's date is?
Yes, October 17th.
Okay. And where are you right now?
The PDA, it's in Lindgren Hall.
Okay. Now I'm going to tell you 3 words, and I want you to remember those words.
Okay.
Watch, penny, apple.
Okay.
Can you repeat them back for me?
Watch, penny, apple.
Okay. And then now, there's a pen and a piece of paper, and I need you to draw a clock, and I want you to set the time at 10 minutes past 11.
Ten minutes past 11.
Right. Great. And what were those 3 words that I gave you?
Watch Penny Apple.
All right. So, if there was any question, that's a mini cog. If there was any question, which she did great, then we could do the MMSC or the SLUMS evaluation of mental status. And if any of the questions were concerning regarding her mood or symptoms of depression, then we would ask additional questions about suicide ideation. So there's a few additional tests that may be on cards that will be turned over, and then you would have to demonstrate whichever card you had. One of those would be discriminatory maneuvers. So number identification, you can ask your patient to close their eyes and then tell me what I draw in the palm of your hand.
Do it again. E.
Okay. Keep your eyes closed and then tell me.
4.
Okay. And then on this side.
8.
Okay, great. All right. And this is a writing reflex, which is another good test for Parkinson's, but you have to be careful and be prepared because sometimes it can cause them to lose their balance. So with the patient just facing forward, you're just going to very gently pull back on their shoulders. And for Charmaine, that's no problem to right herself. But with somebody with Parkinson's, sometimes that causes them to fall back. They can't right themselves with that.